Hello. In this presentation, I'm going to share with you the building blocks to create a prevention programme in your practice, how to digitise it to increase its value and effectiveness, and how your business can thrive from starting with prevention. I'm going to cover a prevention model, but we'll lean in further on caries prevention. So if we take a minute to consider dental caries, it is a major public health problem globally, and it's the most widespread non-communicable disease. It is also the most prevalent condition included in the 2015 Global Burden of Disease study by the World Health Organization. There are mountains of research, evidence, and statistics on how preventive measures are effective in reducing the incidence. But my question to you is, why is this still going on? Well, without any doubt, we need improvements. And I will explore these with you using my 4 fundamental for successful prevention. And that includes diagnosing and risk assessment, preventive and restorative treatments, a strong communication model supported by digital imaging, and an evaluation process. Let's begin at looking at the clinical aspect of the patient journey and how that is typically carried out within the structure that you work within, and how that shapes what the patient expects at their appointment. The most common workflow in general practice is for the dentist to conduct the dental examination to the standard that you have set in your practice, and then refer the patient to the hygienist for periodontal health screenings, treatment, and general prevention. Even though a hygienist service is a positive step to delivering prevention, the reality is that unless it is strongly connected to the dentist's recommendations, it is in isolation from total health. So what tends to happen is the dentist operates with their hat on, and the hygienist or therapist does the same. This results to the patient being programmed to expect what they usually receive, no more and no less. Part of my work is that I help clients create systems that enable them to successfully integrate new services and technologies. And although there is nothing wrong with this linear way of operating, it can create challenges when introducing these new technologies and services. If the patient expects your style of exam and hygiene appointment, they could show resistance when you suggest a different way or promote a new service such as prevention. Sometimes the resistance from patients forces us to believe that our patients won't accept a different way or different recommendations, and that simply isn't the truth. To successfully change your operations, it requires effort and focus by the whole team to pace the patients through these changes. And any prevention programme should be strongly correlated with the examination by the dentist, and I'm going to show you how. This is an oral health continuum tool that I use with my clients to help them support positive changes for their practices and their patients. On the health side of the continuum is optimum health and function, and your efforts with your patients are to keep them here and work with them through your clinical programmes to support them reaching the health side of the continuum. The opposite side is disease, which is straightforward for clinicians. Through assessments and diagnosing, a treatment plan is made to treat disease and restore function. The middle piece, however, is the neutral zone, where they don't quite reach the benchmark of optimum health and function, but they may not get categorised as needing treatment either. So this is a risky place, and it's either a reflection that your patients need more care, or it is a reflection that they need more education on the benefit of optimum health and function. And so the outcome from developing a prevention programme is that you have the structure, tools and team to pull patients from the neutral zone towards the health zone and prevent them moving in the opposite direction towards disease. So we are now going to explore some examples of health. The strongest foundation to build a prevention programme is to first identify what health is and what your goals are for your patient to achieve. And I have set some examples of what I determine are the benchmarks of health, and that is where a patient can safely attend an evaluation every 6 months or even 12 monthly intervals. I have based this information from the Delivering Better Oral Health document from Public Health England, and have also added in some additional tools that I know work well in developing a preventive programme. Let's first explore caries. So health would be no signs of demineralisation, high buffering capacity in saliva, good plaque control, healthy diet, regular fluoride, products that have been recommended relating to their lifestyle, and the patient being engaged and motivated. Now, if we look at tooth wear, now this example is mainly describing erosion. No evidence of erosion or erosive diet, no evidence of past wear. You're doing screening using the BB index. You have high buffering capacity in saliva, tailored products, and good patient engagement. And again, with periodontal health, consistently less than 10% bleeding, no systemic or controlled risk factors, non-smoker, well motivated, engaged, and using tailored home care products. And finally, for oral pathology, no risk factors or no evidence of pathology. So you should create what your benchmark is for health in your practice. And once you have it clearly defined, you need to develop a communication script as a guide as to how you're going to position the message to your patients. This type of messaging should be included in your marketing, patient education, and on treatment plans and estimates to ensure that there is always a consistent, strong message. Although the dentist may still carry out aspects of the hygienist and the hygienist of the evaluation rather, and the hygienist will carry out their part, they're hearing it collectively and they're hearing one message that you're both working with them to achieve optimum health and function. So this is the first step to begin to program your patients of how you're working and your goals for them. So once you keep repeating this, it helps the patient perceive the purpose of their visit is more than a checkup and clean, and they begin to value your expertise and the purpose of the appointment. The next stage is to adopt tools, technologies, and products to enable you to streamline it into one process that's shared amongst the whole team and is effective and efficient. So when you begin with prevention, your mindset must evolve from only looking for disease and move towards evaluating and comparing that against your optimum health and function benchmarks. Conversations move from you need X, Y, or Z and move towards describing their condition compared to optimum health and function and what they can do to intervene. This is a much simpler process for patients to understand and be on board with your recommendations. From that position, speaking about treatment needs are more meaningful and, of course, more engaged. The more engaged the patient becomes in their oral health, the more interested they are in listening to and understanding the benefits of intervening to restore optimum health and function. Investing the time in education supports them being able to make an informed choice. So once you have your patients here, just like the Maslow's hierarchy of needs pyramid, the tip is self-actualization, where you can be the best. You realise all your potentials, your patients value you, you value them, and you get better outcomes with them. So to summarise, do not evaluate conditions in isolation from each other, and instead position your intention for every patient and what you want them to achieve. Always make recommendations based on achieving the goal of optimum health and function and outline the consequences of not achieving that. Clearly document everything in your notes so that any clinician can follow up on recommendations. And when you become more cohesive as a team, a norm would be the hygienist following up or initiating a conversation of Invisalign, or a dentist following up and initiating a conversation about recommended fluoride therapies. You're like a tag team, and the nurses become a critical piece in this too. Co-diagnosis powers a successful prevention programme, and that is when the patient is fully involved, understands, and is pretty much in the driving seat for creating the oral care plan. This takes pressure off the clinician and makes the whole process much more aligned. Every discussion should be around the plan to help them reach optimum health and function, whether that is treating disease to bring about improved function and stability, minimally invasive dentistry, or preventive applications and education. This is a constant cycle because when your patients are having treatments and restorations, we need to start with prevention to lessen their risk of secondary disease and avoid any unnecessary new dentistry. Now, visual aids strengthen our ability to communicate with our patients. You will have heard the term that a picture is worth 1,000 words. And thinking back to the beginning of my dental career, we would use printed diagrams and images to communicate our messages. And then intraoral cameras became the must-have tool and are still very highly effective today. But now with the highly sophisticated intraoral scanners, we have imagery on steroids. The iTero 5D Plus scanner not only has amazing quality imagery, but has many added functions that truly support the whole prevention model and can be used by the whole team. With one scan, we can see the 3D image of the whole dental arch, which shows malalignment in a very different light compared to what the patient is aware of. It highlights areas of inflammation and shows calculus and staining deposits. It's very clear to see open margins on restorations. It can demonstrate occlusion, and using the NERI technology, it can detect interproximal lesions, determining if they have reached the EDGA or not. Plus, you can monitor tooth wear using the time-lapse function, and so you can be very proactive in supporting your patients in the management of tooth wear. So once you adopt a comprehensive preventive program that enables you to prevent disease and restore function, then the iTero system essentially becomes like a team member that you can't do without.
So this is the iTero Elements 5D Plus system. As ever, it's a really, really nice, sleek design, but we're going to move in and show you some of the functions of the system. So I'm going to play you a little video, and this video is just going to demonstrate how by sliding the cursor over the teeth, how we're able to look at that, look at the interproximal caries using the NERI function. So you can see by just hovering over, we're able to change the views and the positions, and you can see there that we have some interproximal caries that's been highlighted. And so we'll look at that we'll look at those more closer. So this is a view of the lower arch. And what's amazing is that you can see all of the anatomical features of the teeth. So really in one view, rather than discussing lots of individual elements with the patient, you are able to show them this view, and it cuts a lot of the communication and the time spent explaining out. But really what we're able to show the patient is we're able to show the patient if there's any tooth wear. We can see if there's any staining. You can see on the lower anteriors that there is some crowding there. So if that patient had some inflammation, there's an opportunity to bring up a conversation about, have they thought about tooth straightening for health reasons? So a lot of patients, we don't open up conversations about tooth straightening because they have told us that they're not interested in cosmetics. But actually when you then turn it into the health benefit and you can demonstrate that to them, it's really quite powerful. And a lot of patients are interested for health reasons, which is great in our prevention model. But if we really focus on the between the 5 and the 6 where it's highlighting, and if we move over to the right hand side, you can see the NERI image. Okay, now what it's showing us is that on the mesial of the 6, we have this white area here. Now when you're looking at this image, it's almost like you're looking at a reverse of a radiograph. So with a radiograph, you have an opaque enamel, and then you have a radiolucency suggests where we have caries. But in actual fact, what this is doing is it's using light. So the lights are kind of beaming through the enamel, and because the enamel is dense, it just passes straight through. But obviously in the dentine, there's a lot more space with the tubules, and so the light has room to bounce around and it reflects, and it's that reflection back that gives us that white area. So the white in the middle of the tooth is dentine, and that's represented with a darker outer layer, which is enamel. So you can see here that we've got this white lesion here, and that has indeed extended into the amelodental junction. So this would require restorations. And so on a radiograph, the question is, well, can't you see that on a radiograph? Well, possibly, you may be able to see it on a radiograph, but the difference between the radiograph and this image is that this is a 3-dimensional view. So by moving the scan around, we can actually look at this lesion in a lot different depths, whereas with a 2-dimensional image, as we know, there can be lots of factors that can hinder truly what's going on. So although this isn't preventive dentistry, if this tooth was to show a different type of image compared to a radiograph, then it is giving us information to intervene perhaps earlier than that might be possible. And then, so if we move onto this, onto the upper arch, again, what's really good is we can see the staining. Most people do not brush the palatal and lingual surfaces to adequate standards. And I love the way that this scan just demonstrates that. I mean, my history of being a hygienist and using every type of way to try and get people to visualize and show them with the intraoral camera. But this image, I mean, you know, it cuts the communication at about a fifth or a tenth probably of the time that I took. So I really love this, showing this palatal image for hygiene and perio-wise. But again, if we look, taking and looking at the 6 that's being highlighted, we can see on the mesial of that tooth on the scan, there's nothing obvious to suggest interproximal caries. And yet on the NERI image, we can actually see that we've got this marked area, which is showing us, essentially what it's showing us is that the enamel is less dense in this area, which is suggesting an interproximal caries. Now, you can see on this one that it hasn't actually reached the ADJ. So because it's not connected to the white, which is the dentine, so there is a bit of a gap in there. So it looks as though there's an opportunity to remineralize that one, and this is where it's really exciting. Now I've got one more image to show you that's a bit more of a storyboard that involves radiographs as well, for you to see that. So this is the obviously the image that was taken. It's between an 8 and a 7. And this is the NERI image. So really what we're looking at is the mesial of the 8. And you can see we've got this really fine pinhead type of lesion that hasn't reached the ADJ yet. Now, on the intraoral camera, there's nothing significant. And on the X-ray, there is no sign of it whatsoever. So we have an opportunity for this one to actually engage with the patient, whether we choose to remineralize the lesion, or we may choose to use ICON to infiltrate the lesion if we feel that we want some more immediate result. But ultimately, this is where it's really, really, really powerful that we're able to show you that. And there have been a group of dentists that have used it that have noted areas on here that they haven't seen on radiographs. So this is where it's really exciting and really, really, it's really interesting.
Many clinicians think about using an intraoral scanner only for Invisalign or only for restoratives. But the truth is, in doing that, you're missing out on so much opportunities for your patients and your business. And instead, you should use it on every patient at set intervals according to their health needs. It is so powerful to look at many of the aspects of oral health in one image and connecting them together to give the patient strong messages. Discussing every aspect of their oral health without it could probably more than triple the time it took you to scan and be not anywhere nearly as effective. So what I'm going to do now is take one element of prevention and focus on the caries prevention programme. So we are going to look at risk assessment, diagnosing, communication, therapies and treatments, home care, and the re-evaluation. The risk assessments. Now this is well documented and should be carried out with every patient. In addition to a risk assessment, a product that I have used that I feel makes this assessment more individualised and meaningful is saliva testing. By testing the buffering capacity in saliva, you know if the patient has a low, medium or high buffering capacity. Knowing this completely changes the landscapes and helps you in your decision-making process. It also places more responsibility onto the patient, and I found it particularly useful when noticing differences in caries incidence between siblings. It's a really nice way of strengthening your message without pointing the finger at someone. So diagnosing. The gold standard is using the ISADAS model, which is the International Caries Detection Assessment System, which identifies that there are 3 stages of early and 1 stage that requires minimal intervention and 2 that require caries removal. This is for visible tooth surfaces, and of course the NERI technology helps to plug the gap for assessing interproximal sites, making it powerful for early detection due to its 3-dimensional view of a suspected lesion. It also has a monitoring function from the safety point of being able to repeat it more frequently. So when we think communication, caries diagnosing is subjective, and the language that we commonly use, although it's not wrong, it could be interpreted differently, therefore might not have the same impact on some patients' motivation. Communication styles when informing patients of enamel lesions are things like, you have some early signs of tooth decay. Now, although this isn't wrong, a patient that values their health, hearing that could be powerful to instill them to want to change. But for someone who just accepts disease, the word early could just dilute the whole message. We could say there's just a little spot of decay. And again, the word little is likely to be chosen because it's perhaps less than the problems that the clinician typically sees, but it just completely dilutes the message. And then when we move on to impart our recommendations, we may say something like, I'll place some fluoride on and keep a watch on it, which is problematic because it places no ownership onto the patient. You may say, I'm going to watch this tooth because it may need a filling. So this message is positive in the sense of giving a patient a consequence, but again, it doesn't place any ownership onto the patient to change their behaviour. So I'm now going to share with you my communication model, which may sound uncomfortable if you position yourself saying it, but it is logical, it's accurate, and I have first-hand experience of the effectiveness of using it with patients. So the magic word is calcium. Many patients know that teeth and bones are made from calcium because it's in public health promotions. Plus, we have all experienced that patient who believes the baby sucked the calcium out of their teeth. And although that's clearly not accurate, it does demonstrate that calcium is a word that most patients can identify with. So I begin by telling the patient that the tooth is made of calcium, and I share with them that there are signs that their tooth is losing calcium. The reaction you see from patients when you say that is what confirmed to me of how highly effective the message was. So I then advise that when they eat any sugar, the bacteria on the teeth use the sugar and spray acid onto the tooth, which dissolves the surface, causing calcium to come out. And I point out that this is the first stage of decay. I describe the progression by stating, if this continues, it will turn into a cavity that will require drilling and filling. It is, however, possible to get the calcium back into the tooth and make it strong again. So the next part is to get commitment that the patient is motivated to play their part in remineralisation. So you ask a very simple question, which is, do you want to do what you can to get the tooth strong again and avoid drilling and filling? Only after you get commitment do you move on to make your recommendations, such as, what I'm going to do today is apply fluoride. What you need to do is reduce sugars to meal times and reduce sugary drinks. Brush twice a day, spit, don't rinse, and then I need you to use this calcium paste a few times a day, even carry it with you and apply it with your finger after meals. This is very good at driving calcium back into the tooth. We need to reevaluate the area in 3 months and reapply fluoride to support what you have been doing at home. Considering interproximal caries, being able to rescan a portion takes no time at all and enables you to continue that engagement with the patient and demonstrate their progression back to health. Don't forget that this is a 3D image and therefore we can observe and analyse the lesion fully to determine any progressions or regressions. The best thing that you can do to successfully implement a caries prevention programme is to have a shorter recall interval as part of your protocol. It is the norm for periodontal disease and it should be the norm for caries. Now, the piece between your recommendations and re-evaluation is to determine the therapies that you recommend, such as fluoride varnish, fluoride mousse in trays, Icon to infiltrate lesions, Fisher sealants, air abrasion and remineralisation. So have these treatments itemised on your dental software. Run a report each month to determine how many of each you have carried out, and that will give you a baseline which you build upon. In the evidence-based toolkit for prevention document, it states that recent thinking suggests that all patients should be given the benefit of advice and support to change behaviour regarding their general and dental health, not just those thought to be at risk. And I think we all need to shift our mindset to truly preventing caries rather than pushing prevention on the patients that have problems. When you run reports on all prevention therapies carried out, you will see how well you're delivering prevention rather than assuming that your patients are receiving this level of care. Most of this should be delegated to the hygienist, therapist and nurses to deliver the care and education within their scope of practice, which, if we consider the first slide where we have the dentist doing everything and focusing on looking for disease, instead the team are doing everything with a focus on health. The dentist uses this information further to consider optimum function and treat any disease beyond prevention. To summarise the stages in building the ultimate digital prevention programme, you need to define optimum health and clearly document that. Be clear on the goals for your patients and create a verbal script that describes how you would communicate that with your patients. Define optimum health and function. Ensure everyone is comfortable with communicating that message. Develop your risk assessments and think about other products that you can bring into that. For example, saliva testing, which is very useful for risk assessing caries and erosion. Invest in technologies that have multiple functions and support a total prevention programme, and have the capacity for monitoring as well as restorative and tooth straightening workflows. Make sure that you use them on every single patient. Utilise the Skillshare mix of the whole team with the mindset of supporting optimum health and function for your patients. Develop protocols for monitoring that connect treatment and preventive pathways. Develop your preventive and restorative pathways and protocols. I gave you an overview of a caries prevention programme, and you should develop a similar structure for complete oral health. And realise your opportunities. Having all the prevention protocols in place, having clear goals for your patient, changes the landscape of looking for disease in a linear way of working to opening up all the opportunities you have for your self-development, your patient's health, your career and your business. Thank you for your time and interest. I hope you got some value and insights into a prevention programme and the technology that supports a 360-degree prevention approach. If you want to find out more about how I support dental practices and the coaching programmes that I run, you can find out more on my website floracouper.com and loveyourdentistry.co.uk, where our courses and educational content is hosted. Also, if you're left wondering about the neurotechnology and caries detection, why don't you take the caries detection quiz, which you can access by scanning the QR code. Thanks again for your attendance.